Okay. Hi, this is Dr. Shanti Mohling, and
This is Dr. Richard Rosenfield.
and we are here today to talk with you about one of the most common surgical procedures performed on women in the U.S., which is
Hysterectomy.
That's right. And I would say that hysterectomy probably represents at least, about half of what we do around here surgically in our practice? Definitely close to that.
Yeah, I think often, especially because we're a referral base.
Right.
It's not that we just do hysterectomy on everyone.
Right.
It's that when people do need it, they're referred to us because we can do it laparoscopically, minimally invasively, and very often end up in the outpatient setting.
Yeah, and that's what we wanted to talk about today as part of our webinar series, is really to kind of focus on hysterectomy and frame it up a little bit as to, first of all, who are the type of patients that have this type of surgery and why, and then a little bit about our program here at Pearl Women's Center and maybe what makes it unique compared to other options that are out there. So let's just jump right into it. And first of all, talk about the fact that 1 in 4 women by the time I think they're age 65 will have a hysterectomy. And that is something like, it ends up being close to 600,000 hysterectomies being performed in the United States alone each year. What's interesting about that, though, is when you look at the number of doctors that are in the United States that are OBGYN providers, and you divide the number of cases done by the number of doctors, you end up realizing something that's kind of scary, which is that a lot of these doctors really don't do a lot of surgery. And so that's part of the thing that we want to sort of express as a difference, is that if you need surgery, it probably makes sense, at least in the United States and big cities, to find someone that does a lot of this stuff. Would you agree?
Absolutely. I mean, if you are in a more rural community, your provider may only do a few hysterectomies a year. And so that skill set is not really being maintained at an optimal level.
Yeah. So, okay, so Dr. Mohling, let's talk a little bit about the reasons that women have hysterectomy. So what would you say the top, 2 to 3 reasons in your practice over the last 20 plus years you've seen patients that have needed hysterectomy? What would those reasons be?
So I would say the top 2 are heavy menstrual bleeding that is not responsive to other measures, such as progestin, IUD, birth control pills, or hysteroscopic procedures. Nothing seems to help stop this bleeding, and so they're choosing hysterectomy.
And this would be typically in women that are done having babies, of course.
Absolutely,
yeah.
and they're seeking the hysterectomy. I'm
right.
not telling them they have. I very rarely tell someone that they have to have a hysterectomy.
Well, and as a matter of fact, I think a lot of the insurance companies that we deal with, they actually require that in order to be booked for a hysterectomy, that you've already tried these uterine preserving things. So,
Indeed.
Okay. So,
and then the second thing is pain.
Pain. Okay.
So the things that cause heavy bleeding and the things that cause pain are sometimes similar. So adenomyosis, fibroids, endometriosis, those things contribute to heavy bleeding and to pain.
Yeah, and maybe we can dive into that. So some of these things are anatomical, right? So if you have an anatomical problem with your uterus that it wasn't created the same way as other women's uteruses would be, for example, fibroid tumors or other benign, so non-cancerous tumors of the uterus, those can be very difficult to find another pathway. There are some uterine preserving surgeries, but sometimes they just don't really give the patients the results that they want.
Right. Would you say that that's the same pattern for you in your history?
Yeah, definitely.
We've been practicing about the same
Yeah, we have
years.
been. We both started out right around the early 2000s, and our practice I think has changed a bit. It used to be, at least years back, that very few women were educated about their options, and so when they heard the term hysterectomy, they immediately went to this place that probably was more common with our parents' generations, where if you were going to have a hysterectomy, it meant that you're going to the hospital. It meant that you're going to have a big incision across your belly, yay big, and oftentimes it meant that you were going to lose your ovaries.
Exactly, and even if you were 25, 30, 35. And now, really, the teaching is that if you have healthy ovaries and you are under the age of 65, the literature supports keeping your ovaries and approaching menopause naturally. And that has to do with data that shows that keeping ovaries decreases morbidity and mortality. Interesting.
Right. Right.
So generally these days we might remove fallopian tubes, but
Right.
very rarely ovaries unless they're abnormal or a patient really strongly requests removal due to concept that their pain is coming from their ovaries. I want to initiate this next section of our discussion by asking you, Rick, about this whole history of you having this outpatient center. Like, you were really the first person to develop an outpatient surgical center that included hysterectomy. Probably, in the country.
Yeah,
so
it's been a long time.
Right? So tell us a little bit about that.
Yeah, my previous work, when I was working as an employed physician for Kaiser Permanente, a huge group in town, we did a lot of work in the hospitals. And I kept thinking back to this opportunity I had when I was in my training where we worked at an outpatient surgical center. And I was trying to figure out whether there was an opportunity at the time just to send our patients home the same day so they could sleep in their own bed, because we were making these little tiny incisions and we were doing laparoscopic surgery, and the patients that evening, they weren't being required to be on any sort of IV medication. So really what we were doing is we were keeping patients in the hospital to give them pills and to check their vital signs. And most patients would agree that they'd rather be in their own bed. They would rather be taking oral medication. And then there's also the added cost of being in the hospital. But I think it was really this opportunity to recognize that most of us know at the end of a surgery how it went, right? I mean, we have a pretty good idea whether or not the surgery went well. And I think based on that understanding and thought about how the surgery went, we would have a pretty good idea of whether or not we needed to be involved in the next 8 to 12 hours of management. And it became pretty obvious that that just wasn't going to be a requirement. And so that's when we decided to try to do this stuff outpatient. This was, over about 15 years ago that we got started with this. And it's been really exciting just because it's caught on throughout the US and really even internationally, this idea of trying to get patients home the same day, and even more of the idea that if we can avoid using the hospitals and leave the hospitals, especially in a time like COVID, where we really understand that patients are sick and that they have transmittable illnesses.
Right.
And if we can keep them away from the hospital, it's the same thing with things like MRSA and all these really bad bacteria that we hear about. Our pathway of doing things outpatient is not only cost effective for the patient and for the person who's paying the bills, typically their insurance company, but it really does deliver a higher quality experience, and even our outcome data is better.
Yeah. So it's interesting. I have now been working here at the Pearl Center for a year. And when I first got here, we had one patient who had pain after surgery and we ended up admitting her to the hospital for pain management. But that is the only person in a whole year. And my guess is that when you first started, there may have been a few more admissions, and that over time, you've had fewer and fewer.
Yeah, I mean, the admissions have been low. I think that what we've learned, and with a lot of your help as well, is how do we prevent post-operative pain, right?
This is a big topic.
So
that's
a lot
dear to my heart.
very dear to your heart. So at first, we just basically told patients, you have to go home. You don't have a choice. Now, it's going to hurt, but you're going to go home because you can take pills. You don't need to be hitting the little pump for pain medication. But then we started really embracing all of these enhanced recovery protocols. And I'm very proud to bring Shanti into the mix because she's actually published on this. And one of the things that she's published about is something called a TAP block. And I'm just going to hand it to you to explain what that is, because it's really cool. I wasn't a huge believer at first, but the data speaks for itself and the patients speak for themselves.
Right. And I think one of the biggest things that began to convince you is our recovery room nurses love when we do tap blocks, because the patients go home quicker, they seem to be in less pain, they get up and they can void more easily. So
now tap doesn't mean tap.
What a tap is a transversus abdominis plane block, and these had been done previously to my work. They've been done mostly by anesthesiologists with an ultrasound guided needle injection, kind of like when you go to the dentist and you block the nerves here. This injection blocks the nerves of the pelvic or of the abdominal wall. And so we do this under laparoscopic guidance, so it's very quick. You don't have to have it done afterwards by the anesthesiologist with ultrasound.
So it's not like an epidural. This is actually done in the abdominal wall.
So it's very safe.
Yeah.
In my study of, probably 200 people, over 200 people, 2-point and then 4-point. Some of that data is published, some of it is not, but we didn't have any complications of the tap block.
Right.
So it's a very safe way to decrease pain after surgery and decrease the need for opiate medication.
And it's kind of like a preemptive strike, right?
Yeah,
Instead
so we
of
do
waiting
it at the
for
very
pain,
beginning.
instead of waiting for pain, what we do is we inject before we even make an incision.
Yeah, we make just the first incision to get the camera in, and then we can do the block before we do anything else.
Right.
So that's one thing. And then we also use some non-opiate medications to help with same-day discharge. And that does help limit the use of narcotics. Sometimes I often call my patients after surgery. I remember calling someone just recently, and they had not taken a single pain med, and it was 2 days after surgery.
Right.
So I know that this makes a difference.
Right. And this is something that's interesting because it started out back in 2005 when we were doing these. We did a patient, we did 10 patients, we did 100 patients. Now it's thousands of patients that have been through this. And some of these patients, they're from all walks of life and all sizes and shapes, and they all seem to do beautifully with the laparoscopic approach and kind of preemptively going after these receptors. So we're not only trying to prevent pain, we're also trying to prevent nausea. Because believe it or not, nausea is one of the biggest problems we deal with post-operatively with patients as well. A lot of people don't realize that when you're having laparoscopic surgery, you're not flat on the table. We're actually kind of standing you a little bit on your head. And so there's things that we can do to manage the reaction to the anesthesia. We do something called total IV anesthetic. Do you want to maybe explain what that is?
You explain. Go ahead.
Well, instead of using inhaled gas.
Yes. Right.
Okay. So historically, if you would talk to some of the anesthesiologists that are, maybe in their 60s and 70s, anesthesia was kind of a one-trick pony, if you will, in the operating room. You would basically breathe inhaled gas, and that's what would knock you out as a patient. And unfortunately, when you breathe gas like that, it can make you really sick. So there's the good side of it, which is that you're asleep, but the bad side is you wake up with a terrible hangover. Yeah. So we can run the medication pretty much exclusively through the IV now, which is really effective. Patients are still intubated, so we protect their airway. And when we do the surgery, it's just like having surgery in a hospital. The operating room really looks similar.
Yeah.
It's maybe a little smaller.
In fact, we have some of the better laparoscopic equipment.
True. That's very, very true.
So another thing, you brought up nausea as a post-operative issue. Another really significant issue is constipation.
Oh, yeah.
And this is something that we hear a lot from our patients after surgery. And so the tap blocks, because they decrease the use of opiate medications, help by, so opiate medications increase constipation. The tap block helps decrease opiates, which decreases constipation.
Yeah. Absolutely. Absolutely. Now let's talk a little bit about the actual surgery itself.
Yeah.
So what would you say, so especially coming out of academics, so Dr. Mohling here was recently working at the University of Tennessee, Chattanooga, where she was working with medical students and residents and fellows. And in that program in the hospital, how long would it take for a hysterectomy to be performed typically? Like, what would you say the range would be? It's different with you, of course.
Yeah, but when you're
teaching,
when you're teaching, it always takes a lot longer. 3 hours at least, probably 4. And so it's such a pleasure to. Rick and I often do our surgeries together. Sometimes we still have a fellow, which is a lot different from a resident or med student. But when we do our surgeries together, even complex hysterectomies only take at most 2 hours.
Right.
And so that's really a pleasure, but that also minimizes the amount of anesthesia someone is getting.
Right.
I would also say our blood loss is incredibly low.
The acceptable blood loss here.
Right, because we know we don't have...
minimal to none, which is really awesome as well, because when we think about the things that can happen during surgery that would be considered, complications or untoward events, one of the things that we get worried about is, first of all, an unpredictable complication like bleeding, right? Other things that could lead to hospitalization would be something where we have to open the patient, right? Like a conversion to open. And that's a really good thing to ask your doctor about. If you're interviewing physicians and you're thinking about having surgery, and you're thinking about a laparoscopic surgery, you can ask your doctor, what's your complication rate? What's your conversion to open rate?
How often do you open? When was the last time you opened someone?
I don't remember, which is a
Me
good thing.
either. I don't think I have.
Yeah, I think we had one conversion to open. There might have been 2 conversions to open. I'm going to just get that. There we go. In the entire history of our surgery center, which is pretty awesome.
Yeah.
But a lot of it's planning. I think planning is huge. Planning and the team.
Choosing patients who are acceptable candidates for the center.
That's right.
Which is most patients.
It is most patients, that's true. So let's maybe give a couple examples of a patient that maybe wouldn't be a good choice for the surgery center.
So uterus that is really over 20-week size. So the uterus extends way above the belly button. That might be a little too big to comfortably do in the center.
And then sometimes with body mass index, there might be some related issues with profound obesity. So typically if a body mass index is above about 44, most of the anesthesia societies do not recommend ambulatory surgery for that. And then sometimes comorbidities, if you're a patient that is on blood thinners, if you've had a cardiac history, things like that, we would definitely recommend going to the hospital. And we can certainly do that in those circumstances. But the vast majority of cases that get referred to us are great candidates for outpatient laparoscopic surgery. Yeah. So we would love to answer your questions.
Absolutely.
And we're both available on social media. You can absolutely reach out to Pearl Women's Center. And all of our information should be somewhere linked to this video. But info@Pearl Women's Center, or you can hit us up on social media as well. We love answering questions. And we are going to continue to do some interview webinars like this over the next couple of months to try to accommodate the needs of our patients. So please let us know what you want to hear about, and we'll do this again soon.
Absolutely. Thank you.
All right. Thank you very much.